we're going to move on to Dr. Ricci's recorded interview concerning his OTA highlight paper for risk factors of the failure of lock plate fixation of distal femur fractures.
I thank you for joining us, Dr. Ricci, to talk about your OTA highlight paper, Risk Factors for Failure of Lock Plate Fixation of Distal Femur Fractures, an analysis of 335 cases. Can you start off by talking about what was going on at the time with distal femur fracture fixation that prompted the study?
Yeah, sure. Again, thanks for choosing this article. At that point in time, locked plating was relatively mainstream and was used, I wouldn't say exclusively, but nearly exclusively for the treatment of distal femur fractures. And it sort of supplanted non-locked fixation and was sort of transitioning to supplant fixed angle fixation like blade plates and DCS devices, assuming you're going to plate. If you're going to nail it, it's a whole different conversation. So lock plating was becoming more and more popular, and there was some evidence in the literature that there was a modest non-union rate with lock plating of distal femur fractures. And so what prompted the study was we wanted to see what factors were associated with healing complications when using lock plates to fix these fractures.
And can you summarize some of the main points and findings from your article?
Yeah, so we found that some of the factors were completely out of surgeon control, and some were within surgeon control. And that's one of the goals of the papers. There's certain things we as surgeons can control and should and can modulate, and others we really can't. So we found that, not surprisingly, that there were some patient factors that contributed to risk of healing complication, namely open fracture. We have no control over that. Diabetes status and patient weight. Heavier, bigger patients, a little higher non-union rate, open fractures, and patients with diabetes. And then the one factor that was within surgeon control was the length of proximal fixation. And I think at this time period, this was when the length of plates that we used was relatively variable. And I think today, most surgeons are using relatively long plates, and what is that? And we'll talk about that. What is long enough? But some at that period of time were using relatively shorter plates. And so what we found was, it's a little hard to normalize in millimeters, but like hole length, 8 holes or longer was associated with less risk of fixation failure than shorter plates.
I read it in your paper that for open fractures, the average metaphyseal void was 7 centimeters. How do you decide how much to debride for those open fractures, and has that changed over the years?
Yeah, that's a really good question. That was the subject of actually a follow-up study that we did with Corey Collins, was one of the co-authors. And in discussing this issue with Corey, it became apparent that his sort of protocol was to do sort of minimal debridement of bone. And our protocol at the time was to be more aggressive. And so we looked at that. And so what's the optimal amount of debridement that should be done? Still, again, up for debate. The more debridement you do, in theory, less devitalized bone, less chance of infection. But the more debridement you do, the bigger the defect, the harder it is, and the more procedures it's going to take to get this individual to heal. And so what I took away from that is, if this is a contaminated wound and there's contaminated, clearly devitalized bone, well, that's got to go in the bucket. But if this is a relatively clean wound and you have marginally viable fragments, I err now towards leaving those in that situation. But this is a little bit of the art of surgery.
In your manuscript, you had mentioned titanium and steel. Have you found that to, be important in these fixation constructs?
That's something that's a subject of a lot of different papers and a lot of controversy and a lot of conflicting results. And if you look critically at this literature, and this is sort of a whole nother point to be discussed, is whether you're using stainless steel or titanium has an impact on the stiffness of the construct. And locked screws versus non-locked screws and the quality of the bone also has to do with the stiffness. If you don't mind, I'd like to come back to that. But what all of these papers, almost all, fail to do when they analyze this is to look at the construct. Was the construct designed to compress a simple fracture, and was that construct designed to induce primary bone healing? In which case, the stiffness characteristics of your construct are different than if the construct, this was a comminuted fracture that you spanned and you did a bridge plating technique, and your construct was designed to induce secondary bone healing. And the stiffness parameters of that in an ideal situation are different. That parlays into the, should you use locking screws or non-locking screws in the shaft. And actually, we have a manuscript that's just being submitted that shows that if you have good quality bone in the shaft of the femur, it makes absolutely no difference whether you use locked or non-locked screws to the stiffness of that construct. And that actually is contrary to popular belief, but it really does make some sense. If you've got good quality bone, you've got good fixation of your non-locked screw, and if you used locked screws, you'd have good fixation with your locked screws. In either one of those situations, there's going to be essentially no motion between plate and bone in the shaft. And so the stiffness that your fracture sees, or the strain that your fracture sees, is dictated by the working distance and the material. And whether these screws are locked or non-locked in the shaft really makes no difference whatsoever. That situation is different if you're talking about osteoporotic bone. In osteoporotic bone, when you put purely non-locked screws compared to purely locked screws, there's a difference. There's not really much of a difference at time zero because both will have good fixation, but over cyclic loading, non-locked screws in osteoporotic bone tend to loosen. And so the construct starts to fail. But the bottom line is in osteoporotic bone, non-locked constructs are less stiff than locked. I would agree with that after cyclic loading. But in good quality bone, it really doesn't make any difference.
How did the results of this study sort of change your practice?
So it emphasized the need for longer plates, at least 8 holes spanning the proximal fragment. And again, I think some of the offshoot studies from this, it changed my debridement protocol. It was a little less aggressive for the clean open fracture. I think that was important. I think those are the two main things that came away from this. And then it prompted the biomechanical study that I mentioned of locked versus non-locked to give us a little bit more clarity on that. And I think it just prognosticates that, the diabetics and the obese and the open fractures are just bad actors. And that's the group that we probably should definitely think about adjuncts of some sort, whether it's a medial plate, whether it's a nail plate construct, whether it's some biologic bone, acute bone grafting. So I think that was another take home. I have acutely bone grafted some of these more severe fractures a little bit more after this study than before. Again, it's a known diabetic, relatively obese patient. I don't acutely bone graft open fractures, but if it's a closed fracture in a high-risk patient, that's something to consider.
Awesome. Well, I really appreciate you taking time to discuss your great article with us.
Yeah, appreciate it. And thanks very much. Of course, thanks to the co-authors. I mentioned Corey Collins and the guys in Seattle that contributed a lot of cases. We had 300 and some odd cases. So it was a big study that took a lot of effort from 3 different institutions.